Good evening, all. My pleasure to have a small discussion before our speaker, Dr. Ashok, joins us. As you all are aware, we know that sepsis is the most deadliest diagnosis which we have to make in the emergency department. And we'll always be thinking whether this is the four parts of the sepsis, whether it is SIRS, sepsis, septic shock, or severe multi-organ failure. And always it is a challenge in the emergency department for starting an antibiotic, looking into the evidence-based medicine, which antibiotic to be started, when it has to be started, whether it has to be started before a culture has been taken or after the culture has been taken. So these many questions are always logging at the back of the mind. And since I have been practicing since 25 years plus, always this mindset is with me also, that okay, should I start this antibiotic or that antibiotic? Where is the sepsis foci? How should I look into this sepsis foci? And along with sepsis, there are many things which is important. Whether this patient has to be looked into whether this the total counts, whether I should see the complete blood picture and then start it, or should I start it right now and look into the fluid status of the patient, whether I should do an ultrasound in the emergency department to look into the IVC status and then give the fluids, and when to start the inotropics, which is very, very important. And before the intubation process, like patient is ready for intubation, whether you have to start the inotropics and then continue with the intubation, or do the intubation first and then start the inotropic agents. So these all questions will keep on being continuously at the back of our mind. And for these questions alone, we as emergency physicians should be knowing what are the guidelines which is continuously keeping on changing. When I started the practice, it was 6 hours bundle, then it became 3 hours bundle, now it is 1 hour bundle. So that is how science is changing. And we being emergency physicians, we have to update ourselves and keep up to the knowledge and look into what best we can do. So with all these questions in back of my mind, that's how we chose the speaker for the day, where Dr. Prasad will be introducing to you about the speaker details and taking to you forward. And we from Society for Emergency Medicine India or Yashoda group of hospitals, we are always intended to start and give the best academics to all the residents who are looking into this across the world. And with this knowledge and the evidence, you can go back and ask questions which will be helpful for the person who is teaching, that is Dr. Ashok, who can answer you all the questions and ensure that your questions are not being carried forward to your house. Clear it today and then go back. Over to you, Dr. Prasad.
Thank you, sir. Thank you for the opportunity. And I'm Dr. Prasad, an emergency consultant at Hitec City, Yashoda Hospitals. So welcome you all to the webinar. Today, I take this a great opportunity to introduce you Dr. Ashok, who is an eminent personality, who is a Deputy Medical Director, Emergency Medicine and Critical Care at Vinayaka Mission Super Speciality Hospital, Chennai. So he has done his graduation in Annamalaya University in 2002 and has completed his post-graduation in Sri Ramachandra University 2006, and then fellowship in critical care at Apollo Hospitals in 2012. So I would like to introduce you to Dr. Ashok, sir. Sir, can you throw us a light on recent updates of sepsis?
Yeah, hi. Good evening, everyone. Am I audible?
Yes,
I
sir.
audible? Yeah. Thank you. Thank you so much, Dr. Prasad, for the introduction. And I'm extremely delighted to be a part of this speech, that is sepsis. And I was hearing about Dr. Srinath introducing the topic. And thank you, Dr. Srinath, Yashoda Hospitals, for giving me this opportunity to share my view, indeed not sharing. These are all protocols and guidelines which has been introduced and some amendments were also done in 2002 April. And many of the changes or something very drastic what we practice from now. And I feel everybody, the emergency residents and intensivists, whoever is there in the talk right now, should follow this. And this is also open for discussion at the end of the talk. So if you say yes, I can start my talk. Dr. Prasad?
Yes, sir. Please proceed,
Yeah.
sir.
Okay. So SEPSIS 2022, what's new is my presentation today. SEPSIS, each and every one of you in your emergency or your OPD practice or in ICU would have come across this topic, and people are well versed with the sepsis. And Dr. Srinath was talking about the good olden days of practicing sepsis and management of it. But today we are going to see some interesting key points which will be enlightening us in our future practice of management of sepsis. So SEPSIS 2022, today's talk, I'm going to talk about adult sepsis guidelines, protocols, and management. Of course, I'm not going deep into the pediatrics. Whenever needed, I shall throw some light on it. But of course, sepsis is a very vast area, so I'll be trying to cover the best of what I could do today. And what are the things you are supposed to follow in ER to ICU, and the guidelines and evidences supporting the facts and the resuscitation in the ER and in the ICU. And when I wanted to go through this topic and share the knowledge with you people, I came across a number of literature. I can say some 50 to 60 literatures, which I referred apart from these guidelines, which I'm going to talk to you because I had a lot of doubts to be shared. So I'll be sharing those things also. Next slide. Yeah, let's start with an interesting case scenario. I want you to keep a note on each and every thing which is there in this case scenario. A 78-year-old female comes to you from a nursing home. Nursing home, note that, by an ambulance. The nursing home said that she seems weak and more tired than usual. She had a low-grade temperature this morning and is refusing to eat or drink. She's only oriented to her name, not the place or the date. So what do you want to do next? What's your probable diagnosis? Since her mentation is not so great because of the drowsiness, you can put it into sepsis and septic encephalopathy. You can also see that she's coming from the nursing home and she's a 78-year-old female. So a lot of questions arise in your mind. 78, the physiological factors has to be addressed. And also nursing homes, very common is UTI, the urinary tract infection. And she is very weak and tired. Means her general immunity may be very less, and also because of the age. And then she is refusing to eat or drink. So everything goes in place of sepsis and encephalopathy, or rather than you want to put this as a stroke. But if you want to put this as a stroke, let's see her fast, you know, the arm drift speech and all those stuffs has not been mentioned so great in the scenario. So let's go with both things. So let's see the vital signs. The temperature is 99.4. I want to put a strong note on this, especially for the residents. A 78-year-old female will not have a high temperature because of the poor metabolic responses in the geriatric age group. So if the temperature, you may think this 99.4 is normal for her, but still she may be in sepsis. She won't throw high temperatures. So keep this strongly in mind. BP 90/60 for a thin lady or whatever, for a 78-year-old, the geriatric age group. 90/60, again on the borderline, keep a note on that. Respiratory rate is normal, heart rate is normal. She won't be having tachycardia for a sepsis or a septic shock, again because of a poor metabolic response. Now tell me, do you want to initiate a sepsis alert? I think I have told you the answer yes, more strongly into sepsis. So let's see how it goes. Say yes for this. And there is one more option for that. We were talking about a stroke for her. And you can ask for the CT orders. And he asks you for the results of the neuro examination, which you haven't performed yet. I told you before, you mumble that you'll be back with the information and slink back to the patient's room. Next slide. So putting strongly about this thing into sepsis, these are important definitions which I wanted you people to know, that sepsis is systemic. The SIRS is systemic inflammatory response syndrome. It is a clinical response syndrome of just the inflammation of the organs. Remember, there is no sign of infection in this scenario. It may be completely a non-infectious, or you could not isolate a positive organism or a gram-negative organism in this scenario. It's just an inflammation. That's it. Inflammatory response. What is inflammatory response? Everybody knows that increase in the heart rate, or increase in the respiratory rate, bradycardia, bradypnea, a few increase in the counts or very low counts, all these things, you know. So it's just a inflammation. Coming to sepsis or the septicemia in the blood, it is secondary to an infection. A particular organism should be isolated. The culture should be positive, and that is validated with the diagnosis. Not necessarily always. I'll come to that in the coming slides. Severe sepsis. Severe sepsis means a patient showing all the signs of septicemia with one particular organ being targeted. Remember, one particular organ goes for failure because of the hypoperfusion to that particular organ, and it will be explained by the etiology. Say, for example, if the patient kidney is targeted, the urea creatinine will be elevated. If the liver is targeted, the bilirubins and SGPTs, SGOTs will be elevated. The lungs, patient will be having an ARDs. So one particular organ is targeted, and that is damaged in severe sepsis. At the same time, after the targeted organ is getting damaged and the BP goes down, you call it a septic shock. You start resuscitating with IV fluids, but still, in spite of a good resuscitation, at least for 30 minutes to 1 hour, the patient does not improve. You call it as refractory shock, septic shock, or you call it as septic shock. And it is mandated with the elevated serum lactate levels more than 4 millimoles per liter. So these are the important things we should know in the definition. So how does a patient sepsis progresses? As I told you, SIRS, sepsis, severe sepsis, septic shock, and then multi-organ dysfunction syndrome. The important thing I wanted to put here in this slide is your goal identification in the ER starts from the sepsis itself, which is pointed as a arrow mark. It should be starting from the ER itself, right? Next slide. So if you don't think the scenario, what I told you, is not a sepsis, so if there is a no for that answer, the temperature, as I told you, will not be very high because of the poor metabolic response in geriatric age group. Change in the mentation, she had confusions, could be a stroke or a septic encephalopathy. High heart rate, again, because of the poor metabolic response, or she might be having some hypertensive heart disease where she may be taking a calcium channel blocker or a beta blocker, and her heart rate may be less because of that. So again, all these things goes in favor of sepsis. So the next slide. Yes, it is a case of sepsis, and the patient is in sepsis. That's it. Very simple. I think I have explained everything, whatever is there in the scenario. Yes. Next slide. We did not do the lab investigation for this patient. So we will initial lab, whatever we got from the patient is the WBC is elevated and the hemoglobin is sort of normal hematocrit. That you could see the serum lactate levels are more than 4. If it is less than 2 millimoles per liter, consider the patient is not in sepsis, because serum lactate level is a very important indicator. But how far to rely, I'm going to talk about that in a separate slide. So serum lactate level is a very important indicator in the ER, and 2 to 4 millimoles per liter is where you have to start the treatment, and more than 4, it's a worsening sepsis. So you have to be very aggressive in your treatment. The platelets, of course, are less than 1 lakh. Yes. And sodium is low because of the poor mentation, and potassium is normal, and glucose is also normal. Yes, this is a classical case of sepsis. One important investigation which could say very strongly it is sepsis is the serum lactate levels more than 5 along with the clinical scenario. Always try to correlate the investigations with the clinical scenario. That's very important. Yes, next slide. So the most common infection source is from the lungs. You know, you all people are struggling to treat the COVID for the past 2.5 to 3 years, even till now. So the lung infection is very common. In the past 1 year, we were getting atypical viral infections apart from COVID also. So the lung infections are the more common, and chronic UTI, and then GI infections and skin infections. So these are the list of infections according to the chronological order. Next slide. This is one of the very important slide of this presentation. I want you to put a careful note on this slide. The bundles. Everybody were talking about your sepsis bundles. So it was 3 hours to 6 hours bundles in the previous past, but currently you have to strongly put a note that you have to rely on the 1 hour bundle. 1 hour bundle is nothing great about it. The same 3 to 6 hours bundle what you are practicing, you are sort of forced to do that in the first 1 hour in the emergency department itself. So that is the concept of 1 hour bundle. Simply speaking, I think everybody knows the give 3 and take 3. You take 3 investigations from the patients to measure the seriousness of the illness or the sepsis. That is the serum lactate levels, the blood cultures, and the urine cultures. You give 3 to the patients, the broad spectrum antibiotics to kill the infections, empirical to the patients. And if the patients are behind the fluids, that is septic shock, you give fluids to the patients and maintain a mean arterial pressure of above or around 65 millimeter of mercury. Mean arterial pressure, the fluid should be 30 ml per kg. Body weight is the ideal fluid. Which one to give, the normal saline, the RL or DNS, we will be talking about in the coming slides. So this is to kill the hypotension for the patient if the patient is behind fluids or in septic shock or the serum lactate levels is more than 4 millimoles per liter. Again, after starting IV fluids, still the patient is behind the blood pressure, you start the patient with the vasopressor support. I'm going to talk about that in the coming slides to maintain a map of around 65 millimeter of mercury. Next slide. So same thing, 3 hours and 6 hours bundles, which is sort of outdated. You are going to do the same thing, whatever you have done in the first 1 hour, but in an elaborated way, means you have to reassess whatever you have done in the first 1 hour and see whether the patient is improving in the next 3 hours to 6 hours. That is the concept of 3 hours and 6 hours bundles. You have already measured the ER serum lactate levels. You are going to repeat that after 3 hours and see whether the patient is improved, the lactate levels have come down, and then check the vital parameters, see if the blood pressure is improving with the vasopressor support and IV fluids. So this is what you are going to do in the 3 hours and 6 hours bundles. Next slide. But practically speaking, the 1 hour bundle, is it really easy to follow in the year? It's very questionable. Because most of the centers in the first 1 hour doing all these things, especially convincing the patient and the patient attenders for the financial criteria and the treatment criteria in ICU and ventilator support. It's a bit difficult practically, but still you can try and follow this in your setup. Okay. Coming back to the case, the patient has been getting more agitated, means the sepsis component is increasing more. She may be going for hypoxia, and her BP is still low, and the heart rate is slowly creeping up, and the temperature is slowly going high. What do you want to do now? So next slide. We have to order the sepsis bundle set. We already spoke about to see the level of sepsis. You see the IVC. I think you all people are practicing the IVC concept in your ER. See the level of the fluid status, the mixed venous oxygen, the CVP, blood cultures, and antibiotics. So you check all these things, what's going for the patient, how the patient is responding. So that's how you can proceed further. Next slide. Putting everything together in one single slide. So as I told before, the treatment bundles, you measure the serum lactate level, the blood cultures, give antibiotics, empirical, IV fluids, then vasopressor support, and assess for the patient improvement every hourly. That's very important. The reperfusion assessment includes the improvement in the mental status, the improvement of the pulse oximeter level, the improvement of the blood pressure, the improvement of the urine output. A good resuscitation means the patient should be having a good output. So that is the main concept of doing all the best resuscitation in the emergency room. Next slide. Sorry. Talking about the blood culture, every people in the ER have the habit of collecting the blood samples. Make sure you have to take 2 set of blood samples, at least 10 to 15 ml each in both the cubital area. And before doing that, you have to completely clean that with a sterile gauze using a spirit at least 4 to 5 times by using your cotton and spirit technique. Because if you don't clean it properly, the superficial skin pathogens is what that is basically your streptococcus infection. You may prick the needle through that, and your culture report is going to have a streptococcus infection, which is absolutely not inside the blood. So it will be in the superficial skin only. So you are supposed to clean those areas thoroughly and then take the blood samples. So that is very important. At least 2 set of samples to confirm your test results. And the next thing I want to put a very strong note on this slide is the bottom one is culture negative sepsis, severe sepsis. 47% of the patient, you will not have the culture positive, but still the patient can have sepsis in the blood. And this is one independent predictor of death for this patient. Remember, your culture reports are not going to have any infection, but still the patient will be in sepsis. And this accounts for 47%. You may be thinking the patient is normal, but still there is sepsis and the patient is going to die because of that. So this is a very important phenomenon. I want you people to look into this strongly. Next slide. Sepsis scores. Putting all the sepsis score into one simple nutshell, the sepsis scores are proven to be, I don't want to use this word, but still are not much great importance, useless, right? You have the SOFA, Q-SOFA, mu score, LOT score, many scores are there actually, but they have very strongly put that not one single scoring system has predicted the sepsis in a good way or a better way from the ER to ICU. So it's up to you to decide. So recommendations are against using Q-SOFA compared with CIRS, mu, all these scoring systems. I'm going to put this evidence level in the coming slides from now on, whether it is a strong one or a moderate one or a weak one. Weak is low. I'm going to put that. And if I put new, that is a new recommendation. Means these recommendations are from April 2022. And then the previous recommendations, guidelines, these are all international sepsis guidelines. So those are from 2016. So after 6 years, they have introduced these guidelines with a lot of amendments. And this one is a new one. Means the sepsis scoring system is not of great use for the patients in diagnosing that in the ER to ICU. Next slide. So everybody, I just want to brush up with the scores, but still you people have to know as a student. So your SOFA is sequential organ failure assessment. You have 6 parameters. Those are the respiratory system PO2 by FiO2 and the bilirubin levels, and then the blood pressure map and coagulation, the bleeding, clotting times, platelets, and then the CNS, renal system, urea, creatinine, all this stuff. So there are 6 parameters as displayed here, which you are supposed to measure, and the maximum score is 4. So 6 into 4 is 24. That is the best maximum. I mean, these are the maximum scores, and you have to assess accordingly and then treat the patient. But as I said before, it's not gaining so great importance in the recent past, means 5 to 6 years. Next slide. So Q-SOFA is quick assessment of the same SOFA score. There you had 6 parameters, and here you have 3 parameters. So only 3, and then 0 to 1, that is only 1 parameter is altered, means not that much high risk. And then 2 to 3, you have a high risk for the sepsis. Next slide. Mu score is modified early warning. Again, you have almost all the parameters what you saw in your SOFA scoring system. But here they have elaborated individual scores, like if the patient is having a bradycardia or a tachycardia, bradypnea or a tachypnea. So 0, 1, 2, 3 on either side. So this is how you assess the the scoring system for the severe sepsis for these patients. Patient as slow as possible, the risk is low in mu score. Next slide. Putting everything into one simple slide in ER, your sepsis or your septic shock or your severe sepsis or your MODS is a medical emergency. You have to address this as early as possible, and 1 hour bundle should be initiated in the ER itself. Don't keep the patient much time in the emergency room, because emergency room is not a place for treating a sepsis patient. You are supposed to dispose the patient to the ICU within 6 hours, because the patient needs a multidisciplinary approach, a multidisciplinary care. So you have to shift that to the ICU, and crystalloids whenever needed should be given, and this should be initiated as early as possible within 3 hours. And again, the level of evidences for this points has been downgraded from strong to low in the newer guidelines. Next. How to measure? Dr. Srinath was talking about measuring the fluid management, how much a patient needs of a fluid in the ER and ICU. Remember, your fluid management in sepsis is the key role in the prognostic factor of the patient. If your patient has to improve, you have to be behind the fluid management. Every 4th hourly, at least, sit with the patient. You give adequate fluids whenever needed. Then only your patient is going to prosper. So that is very, very important. And we were having a practice of giving IV fluids by measuring the IVC when it was introduced. But right now, the concepts have changed. You have to do an echo, see the left ventricle functions of the patient. You have to measure the stroke volume variation, the pulse pressure variation. So all these parameters play a major role in the fluid management. Not one single parameter of your IVC alone. Put this very strongly into your mind. See the urine output, see if the patient is getting fluid overload, and you have to come down within the fluids as much as possible. You rely on your vasopressor support also. So taking all these parameters into one single entity and manage your IV fluids. Don't depend individually on your IVCs alone. That's very important. But again, the level of evidence is low. And then your serum lactate levels has to be measured periodically. And then if the levels are coming down, means if your patient is improving a lot. And one of the new concept introduced in 2022 guidelines is your CRT, your capillary refill time, can be assessed as an adjunct to your perfusion of individual organ, especially the peripheral perfusion. Since this is newly introduced in 2022 guidelines, not much of the studies has been done for this, and the level of evidence is again low. Next slide. I was talking about lactate levels in the initial slides. Serum lactate levels is an important biomarker for diagnosing the sepsis. But remember, it is not a direct measure of your tissue perfusion. You cannot directly predict, yes, my lactate levels are improving. I mean, it's coming down, so my organs are getting perfused. No, you cannot put that in the straight line. So it is an important biomarker, but still it's not a direct measurement of your tissue perfusion. People in many centers are using procalcitonin as a diagnosis of the sepsis, but many studies are on serum lactate levels than procalcitonin. Maybe your procalcitonin level will gain importance in the next 5 years, or the number of studies and the study group is very less in procalcitonin levels. So most of the large center trials are based on serum lactate levels. So it's going to take some time for the procalcitonin to decide upon, and the results are inconsistent for the serum lactate levels when it was seen as an individual predictor. Next slide. Okay, procalcitonin, I was saying about it. Don't rely on blood investigation of the procalcitonin. Many centers use it as a prognostic indicator, but make sure you have to compare that with the clinical parameters, the clinical vital signs, the clinical correlation, and then with the procalcitonin. Don't rely upon serum procalcitonin level individually. That's level of evidence is also low for that. And important convincing point is a combination of procalcitonin, interleukin, and D dimers. Combining put in all these three parameters into one single entity is a promising factor to diagnose the sepsis and severe sepsis. Right. Next slide. So whatever I spoke till now is about how you approach the patient clinically to diagnose a sepsis. Now, when you want to come to the treatment part, the antibiotics plays a very major role, because all over the world, not in India, not in my place, or all over the world, the antibiotics is completely misused. The European population alone uses it carefully, because your next newer antibiotics is going to take 15 years, 15 years to come into the market, the newer brand of antibiotics. So you have to rely on the existing antibiotics for the coming 15 years. So use it very cautiously and judiciously. So that's what I want to talk in antibiotics. So the best practice medicine is when your diagnosis is not confirmed, means you have something else in your diagnosis, do not start antibiotics. Be cautious with that. Don't be very blind in starting your empirical antibiotics. That is what I wanted to say. And identify the source of infection and start your antibiotics. You have to be very strong and confident when you start an empirical antibiotic in the emergency room, and try to cut short your duration of antibiotics as much as possible. The previous good olden concept of 7 days or 10 days or 14 days course of antibiotics is completely outdated. Don't do that. Next slide. The possible septic shock, you have to start the antibiotic within 1 hour, means the patient should have signs of all the antibiotics. And if you see the patient has already taken too many antibiotics in the previous past, and the patient is a MD or multi-drug resistant organism, then you can start the patient with 2 gram negative antibiotic instead of 1 gram negative antibiotic, which you are practicing. So you can very strongly do that. But again, it is a newer concept and the level of evidence is low. Next. Suppose if the culture reports have come and if it is sensitive to one particular antibiotic, then you can reduce that 2 to 1 antibiotic. Don't use 2 gram negative antibiotic as soon as the report comes. And very importantly, antifungal empirical therapy can be started as per the new guidelines. But again, the level of evidence is low, and empirical antiviral therapy is not recommended unless otherwise it is proven. Next slide. This is a very important graph which shows you your antibiotic should be started as early as possible. A delay in antibiotic for every hour increases the mortality rate by 4%. Remember, when you don't start the antibiotic for 1 full day, that is 24 hours, almost the patient is gone, the patient is dead. So this is a very important graph to say, yes, it's a very strong one. I mean, the strong medicine to be started in the emergency room itself. Next slide. De-escalation I was talking about. Daily assessment of the patient is very important every day. I practice it in my ICU very strongly, honestly, sincerely, dedicatedly, that I assess the patient every day. Like if the patient is having a fever, the counts are getting increased or decreased, and the patient's vital signs are improving or not improving, X-rays, the ABGs, the IVC, the urine output. So if everything is in the right track, I de-escalate the antibiotic. Sometimes within 2 or 3 days, I in fact stop the antibiotics. So that is very strongly recommended in the newer guidelines. But again, the level of evidence is low. And okay, I'll tell that in the last slide. Prolonged infusion of beta-lactam antibiotics is indicated. Means you put that in your 100 ml normal saline or 25% dextrose, and you give it for 2 to 4 hours. That's very important. The reason why I am talking about a sugar-containing solution is those are the best solutions for a good perfusion of the antibiotic into the cellular compartment. your normal saline is not much indicated. I'm going to talk about that in the fluid slides. Yes, next slide. Next slide. Yes, this is what, no, the previous slide. This is what I wanted to say. Yes, the red round, which I mentioned, is the short duration of course is as effective as your longer durations. Your concept of 10 days or 15 days antibiotic does not make a big difference in the outcome of the patient. Means your patient will be paying very less to the hospital and getting a good treatment if you start the antibiotic and continue that for less days. That's the point I want to make here. Next slide. MRSA, if you have a strong suspicion of your MRSA organisms, yes, you can very well start the empirical antibiotic, but very less suspicion of MRSA, please do not start the empirical antibiotics. Next slide. So putting all these things into one single slide, the sepsis is completely present or it is possible, then your shock is present, and if it is absent. So these are all the criteria which you have to take, and you could see your antibiotic should be started within 1 hour in every area except the sepsis is possible and the shock is absent. You should start your antibiotic within 3 hours as soon as you get your basic blood reports like your total counts and then your lactate levels, all this stuff. Next slide. Coming to fluids and vasopressor resuscitation. Next slide. I was talking about fluid management. Your normal saline is not the best fluid for your good resuscitation in the ER because of many reasons. Some simple reasons I have quoted that in the end of the slide, because it causes your hyperchloremic, your chloride levels will go up, metabolic acidosis, renal vasoconstrictions and worsening the kidneys, the tubules, increased cytokine secretion, and you are worsening to acute kidney injury. So you can go for a balanced crystalloid solutions, means your RL minus your magnesium and calcium in that is a balanced crystalloids. Instead, you can even go for RL solution because the amount of sodium in RL is 130 and your normal saline is 154 for 1 liter. Then you can imagine how much of sodium you're going to give for your patient. So you have to be very clear in reducing the sodium content for your sepsis patient when you give the fluids in bolus. So be careful with that. And albumin can be started for patients when they are behind the fluids. If the patient requires a large volume, you can use albumin to increase the blood pressure. And vasopressors are very much recommended to maintain your map of around 65 millimeter of mercury. And that should be your target with a good urine output. Next slide. So again, taking the data of how much fluid should I give in the first 24 hours, should I restrict or very liberal? We don't have great studies to support that, but put one thing very strongly into your mind: do not push your patient into pulmonary edema or fluid overload. That should be your aim. So it's a double-edged weapon. So be careful about your fluid in the first 24 hours. Thank you. Next slide. Talking about your central lines and the artery lines, if the patient blood pressure is low, if there is a patient is in septic shock, do not try to put your BP cuff and then start measuring the blood pressure again and again. It's of no use. Go for the invasive blood pressure monitoring, that is your arterial BP, and then see your BP directly in the monitor. That is very strongly recommended. But again, the level of quality is low. Sorry. And if you want to start your noradrenaline, it should be preferably started in the central line. If you don't have a central line access, it is permitted to start the noradrenaline in the peripheral line to some hours. It's like 1 or 2 hours, but make sure you start your central line as early as possible. Don't try to prolong your vasopressor support in the peripheral line, because half-life is going to be very less and the amount of drug reaching the heart and increasing blood pressure is going to be low. So make sure you secure a central line. That's very important. Next slide. Yes, this is a very, very important slides for all the students. Your drug of choice when the patient is in septic shock is your noradrenaline. I think I think it's sort of jumbled. Anyway, I'll talk about this. Noradrenaline is the drug of choice. Noradrenaline causes peripheral vasoconstriction and pushes all the fluid to your heart and then increase the blood pressure, because your sepsis, septic shock is a distributive shock. The blood is distributed to the peripheries, and you have to start a drug where the drug is shifted back to the heart from the peripheries. So your noradrenaline causes peripheral vasoconstriction, and then it increases the blood pressure. And after starting noradrenaline, if the BP is not improving, you consider a beta-1 agonistic drug which pushes the heart directly, which causes a myocardial contraction and then increase the blood pressure. So the drug is dopamine. But the problem, everybody knows, the problem with the dopamine is it increases the heart rate. Never mind, you can give good oxygen and you reduce the myocardial oxygen demand, but don't compromise on the vasopressor support. And then if still you can start the patient on adrenaline or vasopressin. These two are very good drugs, but the problem is your vasopressin does not have much studies to prove that it is the best drug. But I think all the centers, even in my center, I use the vasopressin. The dose is 0.3 units. And if the patient is not having any complications of bleeding, then you can very well start steroid infusion, your hydrocortisone 10 mg per hour infusion. You can start, but make sure the patient does not bleed because of the steroid infusion. And most of the people would ask me this question at the end of session. I know that I'm going to answer that now. It's going to increase your sugars. Never mind, you can give a lot of insulin and reduce the sugar level, but your BP is very important here. Your steroid is a very good anti-inflammatory agent when there is a myocardial depression, inflammation caused by the septic component. So your heart will be in severe stress. So the corticosteroids acts as a very good anti-inflammatory agents and increase the blood pressure. Next slide. So putting everything into one single slide, when in need, the patient goes for a shock, the septic shock. The drug of choice is noradrenaline, is the first line, and you target your blood pressure up to 65 millimeter of mercury, mean arterial pressure, and invasive BP monitoring is necessary, and vasopressors peripherally has to be initiated as early as possible, but it has to be switched to central line as early as possible. That is important. And vasopressin is a very important drug which is gaining popularity, but very less studies. Probably in the next guidelines, we can have a strong studies of vasopressin. And then along with your, go to the next slide, I'll explain that there. Yes, along with your vasopressor support, if the patient is having a cardiac compromise, a pre-existing cardiac illness, along with your myocardial depression, then if the cardiac muscle is not working good, then you start your dobutamine. And you can also use levosimendan, which is a drug of choice for acute heart failure. But again, it's a newer introduction into the latest guidelines. And then you can, the level of evidence is low. So your dobutamine or your levosimendan is a very good drug of choice if the patient is having a concurrent cardiogenic shock along with your septic shock. Next slide. Next slide. So talking about the sepsis induced ARDS, the lungs are very bad. So ventilator strategies, everybody knows, if there is an ARDS, the alveolar recruitment has to be done. Your HFNO, high flow nasal oxygen, is much better, a very good drug for hypoxemic respiratory failure over NIV. Be cautious with the NIV because your NIV is going to reduce the blood pressure. So the septic shock may worsen. Instead, if you want, you can put the patient on ventilator to go for invasive ventilation. That's better. And low tidal volume, high PEEP is a good indication of recruiting alveolar, new alveoli. So low tidal volume and high PEEP. I would advise you to go for a PEEP of around 10 to 15. Don't worry about barotrauma. You can, and don't worry about hypotension. You can very well take the patient out within 24 hours. I've tried it in many patients. And if your lower zones are affected, the posterior back is affected with a lot of septic component, the ARDS component, you put the patient on prone ventilation, but make sure when you put the patient on prone, because of the blood recirculation, the patient will go for hypotension. So be careful with that. start the patient on very high vasopressor support and try that. And it should be continued for at least 12 hours. Don't do it for 4 to 6 hours. That's not going to be of no use. The next point is a very vital one. Don't start your neuromuscular blocking agent infusion. You have to give it only in bolus. That is a very strong recommendation, because your continuous infusion is again going to cause a hypotension. And then if needed, go for ECMO. Very simple. Next slide. Stress ulcer prophylaxis, mechanical thrombolytic devices, don't use it. Instead, you go for LMWH. Don't use mechanical devices. Strong recommendation. The quality is also moderate quality. And you can use your proton pump inhibitors for your stress ulcer prophylaxis. GI stress ulcer prophylaxis. Next slide. So roughly speaking, don't use for all this. Don't use all these things for sepsis. Immunoglobulins, no. Vitamin C, no. And polymyxin B, hemoperfusion infusions, it causes bleeding, no. The mechanical thromboembolic devices, I told you, no. Soda bicarb is going to worsen the ARDS by giving carbon dioxide and a lot of fluid back. So don't use it. And don't use gelatins or polysaccharides. Next slide. So the goal of care for the first 3 hours, for the first 3 days has to be explained to the patient attenders what you have planned for the patient. Ventilatory care, plus or minus tracheostomy, what is the fluid management, what is the antibiotic cost, and how long it's going to be used, and how it will be very effective for the patient. Everything you have to discuss with the patient attenders. Also discuss their financial support to the patient. So these are all very important patient things, and then you decide. Next slide. So that's the last slide. So early identification is important. Your sepsis is a medical emergency, and we don't have a strong predictive biomarker or a tool to identify sepsis in the ER. It's purely based upon the clinical presentations and the list of lab investigation. Next slide. Your goal. The goal-directed therapy is the same usual care which you are going to give for the patient with the clinical parameters and the lab parameters. Above all, this point is a very valid one. I would like to highlight this here. Even though talking all these guidelines and protocols, it's up to the clinicians, your intensivist or the emergency physician's clinical capability in deciding what is good for the patient at that moment. So you decide upon all these things. Next slide. So this is the guidelines I was talking about. It was actually rolled out in November 2021, and after the amendment, it was released in April 2022. Next slide. Any questions? I'm done with my presentations. Thank you. Any questions, please?
Thank you, sir. Thank you so much for your reinforcing our sepsis guidelines updates. Sir, I have a question, sir.
Yes, please.
Sir, as you already have emphasized more on sepsis negative, culture negative sepsis. So there are two challenges here, sir. So one is regarding antibiotic de-escalation and escalation, and the other one is convincing the patient and patient attendants. Then how do we manage these two, sir?
You are asking about how to convince the patient.
No, sir. Basically, culture negative sepsis. Now, we suspected a patient based on our clinical description. We suspected a patient is in sepsis. So now we have sent a culture. Culture came out to be negative. So now, how would we go about antibiotic treatment, escalation or de-escalation? And then how would we convince the patient and the patient attenders? Because these days they are also more active, proactive.
Yes. I think one. Yes, I got your question. I think one Farzana Sultana has also raised the same question. I'm going to answer for that. When we talk about culture negative sepsis, it includes your total counts, your lactate levels, your procalcitonin, your lab reports of urine and blood culture, and whatever specific culture, whichever you send. So everything turns out to be negative, but still you suspect sepsis for this patient by your clinical parameters. Whether my patient vital signs are improving, whether the patient sensorium is improving, overall how the patient is presenting to you every day. That is how we assess these CN SS sepsis, that is culture negative severe sepsis. But as you very rightly spoke to me, you very rightly asked, everything will be negative. The patient lands up in death. That is why the highest mortality is in culture negative sepsis. That is 47. I can say almost 50% of the death is culture negative severe sepsis. And the last slide I have put, it's purely depend upon your clinical knowledge, how you put to the patient and treat the patient. So definitely it's going to be a challenging issue for a good clinician. So you have to approach the patient with your previous past knowledge and how you handle all this patient, and you have to go ahead. So what I would suggest, what I'm doing it in my ICU is, I see the how the patient mentation and patient's vital parameters, and I decide upon sepsis. Even though all my reports are negative, I don't rely on that sometimes, and I continue with my antibiotics. And you have to explain the same to the patient attendant, saying that yes, this patient has improved a lot from yesterday because of the antibiotic we are giving, so I'm going to continue. Yes, this patient has deteriorated since yesterday, so I'm going to increase the antibiotics. That is how you have to choose your patients.
Thank you, sir. Sir, I have one more question, sir. Sir, you
Yes.
said we'll start 2 gram-negative antibiotics.
Yes.
So before the culture. So
Yes.
before the culture, how would we know that patient is multi-drug resistant? I mean, patient has got affected by the multi-drug resistant. It's by the local protocols, or how would we go ahead?
I think you answered your question. It is
So,
purely based upon your local protocol. We call it as antibiotic stewardship program, which you develop in your own hospital by your committee. Because in my hospital, I have a set of presentation for the sepsis, and your hospital definitely is going to vary. So for each and every place, you get a set of infection. In my hospital, Klebsiella and Pseudomonas is very common. I think in everybody else also. So it's purely depend upon your clinical knowledge and how you approach these patients, and you decide upon these factors. Your local protocol, I would say, yes.
thank you, sir. You hit the nail on right spot, sir.
Yeah.
Any questions from the audience?
Yeah. I have some set of questions. I'm going to answer. They have posted it in the messages. Okay, how to treat gram-negative, I've told. And how does invasive ventilation compare to HFNO in ARDS? Is it NIV contraindicated in ARDS? Yes, I think I put the same thing in the slide also. NIV is not going to be of great use in ARDS. Of course, you have to put the patient on ventilatory support. That's for sure. And you have also raised invasive ventilation compared to HFNO. Okay, your high flow nasal oxygen and your NIV may be a deciding factor in the initial 12 hours or 1 day for the patient. But ultimately, if the patient lung is going to go bad, you are going to go for the invasive ventilation. You cannot trust or rely your HFNO or NIV after that. So you take a serial X-rays, you see the saturation levels, you see the ABG levels, and decide if your ARDS is worsening. You go for early intubation as early as possible. And role of methylene blue in refractory shock? No, there is no studies, not much of studies, and it's not recommended. No. Any other questions? I think these are all the questions they have raised in the messages.
There was one question online regarding the role of noradrenaline in hypotension and shock.
Hypotension due to sepsis, right?
Yeah. That's what I think, because there was a question online. The question says, what is the role of noradrenaline to support the hypotension in the shock patient? Actually,
yes,
it is the drug of choice, as we all know.
Yes, very much. I think I have spoke about that in my slides. Your septic shock is a type of distributive shock. All the blood from the center, means the system, goes to the peripheries, and it is causing a peripheral vasodilatation. So the BP goes down. You have to start a drug which causes peripheral vasoconstriction and pushes all the blood back to the heart and increase the blood pressure. And that drug is noradrenaline. So that's how noradrenaline acts and increase the blood pressure. Yes.
There are two people who have raised their hands. One is Dr. Priya and second is Dr. Syed Ashok.
Yes, please go ahead.
And also Nandini, Dr. Nandini.
Yeah, go ahead, please.
Dr. Naveen, can you just ask them what is it?
Yeah, Dr. Priya can speak now.
Sir, can you hear me? Hello.
Yeah, I
Yes.
can hear you. Please go ahead.
Sir, as an anti-inflammatory, how much steroids we can give and when to stop the steroids, sir, for a sepsis protocol?
Okay, your steroids actually is a good anti-inflammatory agent. We are not starting steroids for increasing the blood pressure. It just supports the heart by not going back to the worst situation. Your metabolic acidosis is going to be there in your ABG, means your heart is in severe myocardial depression. So the myocardial depression is nothing but an inflammation of the cardiac muscles. This steroids is going to act as an anti-inflammatory agent. If the blood pressures are picking up, if the lactates are coming back to normal, and the patient sepsis component overall is improving, you can very well stop the steroids. That's it.
Okay, so thank you. Can I ask you one more question, sir?
Yeah,
If you don't
please.
mind?
Yeah.
Sir, when to stop this antibiotics, sir?
When to?
Stop the antibiotics, sir.
When your serum lactate levels are coming back to normal, when the patient's fever subsides, when your tachycardia subsides, when your lungs are improving, you can stop as early as possible. Genuinely speaking, I have stopped antibiotics in my ICU on the 3rd or 4th day itself.
Okay, sir. Thank you.
Thank you. There is one more question. Distributive shock, only treatment NORAD, sir, but any other drug to help improve blood pressure and steroids side effect? I think I have answered that. Apart from NORAD, your dopamine, your vasopressin, your adrenaline, all increases your blood pressure during septic shock. These are all very good options. And steroid side effect is bleeding and increase in sugars, and many things also there, but these two things are important when you start that as an infusion, and monitor the bleeding levels. You see your INR and sugar levels. That's it. Any questions?
In the meantime, let me announce the next week topic. It's by Dr. G. Priya. She is an anesthesiology and critical care doctor and she has finished her MRCM. She's associate professor at Department of Emergency Medicine in CMC Vellore. She'll be speaking on eclampsia management at ED at the usual time.
I think Dr. Nandini had raised her hand and one more person had raised it.
Yeah, please go ahead. Hello.
Naveen, can you
Yeah,
facilitate?
they are given access. They can unmute themselves and Dr. Nandini, you can unmute.
Okay. If there is no more questions. There's one more person who had raised their hand. Are they still
No,
there?
sir, no.
Okay.
Dr. Nandan is also not there.
Okay.
If anyone has any more questions, they can raise their hand.
One question in QA. Sir, have you used any other vasopressor in refractory shock?
Okay. Yeah, refractory shock. Yeah, if the shock is refractory and you after using this list of drugs which I listed it here, if it's not improving, then you have to go for your IABP. No other option. Also, you can try your ECMO technologies. These are the available drugs upon studies when the patient is having a refractory septic shock. Hello.
Correct.
Yeah. Okay.
Naveen, if there are no questions, please ask us.
Hello.
Yeah, we don't have questions. So, Prasad, you can just finish.
Yeah. Thank you, sir. Thank you. We appreciate your time, and we have given valuable information to us, and you have answered all questions. You have answered all questions to the point, sir. Thank you.
Sir, there is one more question.
Yes.
Is there any role of steroids in refractory shock?
Yes, so your hydrocortisone infusion can be started in refractory shock, but in refractory, it's not going to increase the blood pressure. Just a supportive adjuvant. That's it. Yes, it can be used.
There's one more question about angiotensin 2.
Angiotensin 2 in shock.
Yeah, refractory shock.
It's purely speaking, there are not much studies about angiotensin 2. There are many things I can quote out of the box, whatever is not there in the guidelines, which people are using across the globe for shock or treatment of a sepsis or whatever, like ulinostatin, like cytokine storm, all these stuff. But exactly speaking, there are not much studies, so it's up to you to decide in your ICU whether to use it or not. You can try. Yes.
Just to add a point, angiotensin 2, if you are using it in refractory shock, it should be combined with vasopressors. Single agent as a angiotensin 2 may not be useful. Am I correct, Dr. Ashok?
Yes,
Sorry.
yes, exactly, sir.
Yeah.
Everything should be added, as Dr. Srinath ji very rightly told. You are not going to start your NORAD alone. NORAD, if not improving, plus a dopamine. If not improving, plus adrenaline. If not improving, plus vasopressin. If not improving, plus steroids. So it goes on like that.
Thank you. Thank you very much,
Yes,
Dr.
sir.
Ashok.
We'll be
Very,
ending this. Thank you so much, sir.
Yeah.
very helpful for all the students.
I want to thank personally Dr. Srinath, who invited me instantly for this talk, and Naveen and Dr. Prasad, everyone. Thank you so much, Yashoda Hospitals.